Yeah.
To have some form of kidney disease, and that 2.6 million actually require dialysis or transplantation. And that according to the global burden of disease, it is predicted that CKD would be the fifth leading cause of death by 2040. And therefore, we need to raise our awareness and also our actions on how to lower this huge global burden of kidney disease. And if we look at the disability-adjusted life years, which are 8 standardized rates, and stratify patients by the socio-demographic indices, we can appreciate that over the last 25 years or so, most of the CKD burden were concentrated in the 3 lowest quintiles of the social demographic index, as outlined by these areas where highlighted in red or oranges. And that this hasn't changed. So even though there are maybe slight reduction in this disability adjusted life years, they remain concentrated in this lowest 3 quintiles. And also when we review the last 20 to 30 years in terms of the global disability adjusted life years for chronic kidney disease by the underlying cause, we noted that among the 700 million cases of all stage CKD were recorded in 2017, and that the global prevalence was estimated to be around 9.1%. And that since 1990, we see this all-age prevalence of CKD increased by nearly 13%, and that CKD resulted in nearly 35 million disability-adjusted life years also in 2017, and that with diabetic nephropathy accounting for almost a third of the disability-adjusted life years. And that chronic kidney disease is not a standalone disease because it is frequently associated with comorbidity, and in particular the cardiovascular disease mortality. This is really nicely shown by several studies done over the years, and that we now also have the KDIGO heat map to stratify the risk of CKD by both the albuminuria and the CKD stages. So there is this constant close interactions between cardiovascular disease and CKD, and partly because these two comorbidities, or these two morbidities, actually share many common risk factors in terms of the metabolic risk factors as well as environmental risk factors. And if we also look at the another analysis from the Global Burden of Disease CKD collaborations that were published in Lancet some time ago, it was noted that 1.4 million cardiovascular disease-related deaths and 25.3 million cardiovascular disease disability-adjusted life years were actually attributable to impaired kidney function. And that this diagram actually show you how this CKD disability-adjusted life years for CKD on the left side and for cardiovascular diseases and the gout that were attributable to impaired kidney function to these 21 world regions in 2017. And there is also another analysis from the United States where they look at the top 10 causes of death and associated risk factors some years ago. And I just want to draw your attention to show the appreciation that among these death causes, in fact, chronic kidney disease was ranked the 9th leading causes of death in the United States. But when you look at the associated risk factors, in fact, dietary risk factors are top or the leading risk factors in both the men and the women. There is also another global burden of disease diet collaborations analysis in 2017, looking at mortality rate attributable to the diet in 195 countries. And in this systematic analysis, one could appreciate that overall 11 million deaths and 255 million disability-adjusted life years were attributable to dietary risk factors. And that among these different dietary risk factors, they were ranked highest in terms of diet high in sodium, low in whole grains, low in fruits, low in nuts and seeds, as well as low in vegetables or fibers. So these are some of the leading factors, but you could also appreciate some factors like high in red meat or high in sugar and sweetened beverages. We're also attributing as key dietary risk factors. And likewise, if we look at the disability-adjusted life years attributable to diet, we also saw similar findings in some of these dietary risk factors. And also, this applies across to different socio-demographic indices, countries as well. So there is also this interesting analysis done some years ago from the IFKF-WKA, looking at the conceptual framework for people living well with kidney disease, and that I would like to draw your attention to how our life is impacted, the patients with kidney disease, their life is impacted by dietary restrictions and impact how they can live well with their kidney disease among the various other different risk factors. So in one of the survey done by also the IFKF-WKA, looking at what are the factors or problems that would impact patients from living well with kidney disease, and that about 7 different countries were being surveyed, and that you can appreciate that the dietary restrictions play a key role in several of these countries, impacting patients from living well with kidney disease. So what can patients do for themselves to live well with kidney disease? Again, they rank some of these risk factors, and you can also see how Eat Smart and Eat Well are actually leading in some of the key issues that were ranked by the patients as to how they can live well with a kidney disease. So therefore, clearly nutrition or dietary intervention are crucial and essential, and that we need to adopt a lifespan approach to maintain kidney health. Clearly, there are kidney-specific objectives by retarding CKD or delaying the need of KRT, or even maintaining kidney health. But also, it's important to optimize patient nutrition status and ameliorate all these different adverse metabolic profiles, and also ameliorate the cardiovascular risk factors in order to improve patients' quality of life, better symptom management, and enable greater life participation for our patients. In fact, the importance of dietary intervention dated back to the 70s and the 80s, back in the Barry Berner, this NEJM paper in the 80s, showing how if you did not restrict your protein intake, one could lead to chronic renal vasodilatation. And in the presence of already reduced renal mass or some metabolic diseases, this could lead to glomerular hyperfiltration, direct cellular injury, mesangial matrix proliferation with injury, and that it could lead to not only albuminuria, but also mesangial matrix expansion, and then glomerulosclerosis, as well as fibrosis leading to kidney disease. Now, this concept was further revived or reviewed in this NEJM review article, showing how both the drug treatment, for instance, the RAS blockade, may act synergistically with the low protein diet together with a low sodium diet as important dietary interventions to ameliorate the intraglomerular hypertension, and by doing so, reduce the mesangial cell signaling and fibrotic procedures, the fibrotic process, and then leading to amelioration of CKD progression. So this concept was actually tested in clinical trials. In fact, there are numerous clinical trials, but this is one of the landmark paper, which is the modification of diet in renal disease groups, randomizing patients into both the low protein diet, which is the 0.58 grams per kilogram per day, versus the usual protein, which is the 1.3 gram per kilogram per day, and over a 36 months period in non-diabetic CKD subjects with eGFR 25 to 55 mils per minute. But originally, this study was perceived as a negative study, but if you analyze this data more carefully, one could appreciate that there is an initial phase where the low protein diet group actually show a bigger reduction, followed by a more stabilization after the initial 4 weeks. And that if you break down into two components and look at that after the 4 weeks from 36 months, clearly there are a significant difference between the two groups. And that this initial a more rapid drop actually simulates several other therapeutics that are now given a class 1 recommendation for kidney disease protection, and that is there is an initial 4 weeks, a more rapid decline in eGFR before a subsequent stabilization in the GFR. So more recently, there is this Cochrane review comparing very low protein diet versus low or normal protein diet, looking at the kidney outcome, which is the end-stage kidney disease or kidney failure outcomes. If we summarize all these studies and pull them together, you can see that having a very low protein diet indeed reduces the risk of kidney failure by about 36%, and that the population being pulled together is around 8,000 subjects, and that the overall effect was highly significant. It is also based on this data that the KDOQI clinical practice guidelines for nutrition has made the recommendation that for CKD 3 to 5 who are metabolically stable, that the KDOQI recommend protein restriction with or without keto acid analogs, depending on keto analog availability, patient preference, and clinical judgment, in order to reduce risk of kidney failure or death, and also to improve patients' quality of life. And that you can see that it was given a grading of a 1A and a 1C in terms of recommending a low protein diet or a very low protein diet with additional keto acid analogs. However, we also know that a low protein diet may not fit everyone, and that we need a personalized precision approach in order to practice or prescribe this nutrition management for patients with kidney disease, or even if they transit to dialysis. However, what we are aware is, in fact, prescribing a protein-restricted diet or a keto analog supplemented diet actually are associated with a whole host of other metabolic benefits other than kidney protective. In fact, you can appreciate how it can ameliorate the CKD and BD axis. It can improve the lipid profile, improves insulin sensitivity, and reduces oxidative stress and inflammation, etc. And also, one of the key measures when you practice nutrition management or a restricted protein diet is that one needs to use a graduated approach by progressively reducing the protein intake amount over time, slowly, and not in one go. And also one needs to change gradually patients' dietary habit from practicing an omnivorous diet to gradually to a flexitarian diet, and then moving away to from a more animal-based protein to a more vegetable-based protein diet, other than reducing the quantity. And so as we know that the nutrition management in our patients actually evolutes over the last 30 to 40 years, from in the beginning where we are providing dialysis to patients, and then gradually we actually recommend patients to go on a restricted protein diet, to now these days where we would take a more holistic approach in dietary management, not just focusing on the protein, but actually to the whole dietary pattern. And that actually, end of last year, we released this 45th anniversary issue to celebrate the 45th anniversary of the International Society of Renal Nutrition and Metabolism, past, present, and future developments. We try to summarize what's happened in the last 45 years in the nutrition development area for kidney disease. And at the same time, we also look at the future directions in developing this area. So here outlines all the aspects that we reviewed in this special issue. And thanks to all the contributing authors, and also thanks to the other guest editors for developing this issue in the Journal of Renal Nutrition, and that I encourage you all to read this issue. But I would also like to summarize some of the key aspects in the remaining time. That is, in the last 45 years, we realized that what we eat actually would determine what we are, and that the diet we take every day would rapidly and reproducibly change and modify our gut human microbiota. And this study very nicely demonstrates how subjects actually adopting a plant-based diet versus an animal-based diet differs significantly in terms of the gut microbiota profile and also in the fecal concentration of the short-chain fatty acids that were metabolized from the carbohydrate and amino acid fermentation. We also had further insights into the role of gut microbiota in determining metabolic syndrome in this mice studies, where that when both different kinds of mice were fed a high-fat diet, the germ-free mice actually didn't show much weight gain, whereas the conventional mice would develop obesity phenotype. By transferring the feces from the obese mice to the germ-free mice, in fact, this germ-free mice would actually also develop the obese phenotype, showing how the feces or the gut microbiota transferred may actually play a central role in determining the metabolic phenotype of the animal. And we also are aware now in humans the same applies, that is, what we eat or what our patients eat or the diet we prescribed, and also the uremia may alter the gut microbiota profile in determining whether they have a favorable gut profile or a less favorable. So for patients who take more fiber intake, there is a proliferation of saccharolytic bacteria, and that would help to strengthen the gut health and improve the epithelial barrier integrity. It also helps this alkaline environment would help to improve the metabolic profile, reduces inflammation and acid load. But on the other hand, for humans who take animal protein predominantly, there will be proteolytic bacteria predominate. There would also be increased uremic toxins generation, and that could also disturb epithelial profile with the uremia, and that these bacteria or endotoxins would translocate, increasing inflammation, oxidative stress, and enhancing CKD progression. So more recently, there is a study looking at dialysis patients, and what you could appreciate is clearly the gut microbial composition is distinctly, uniquely different among those who show a higher risk of death versus those who are having a better survival, as shown by the green bar for the survived patients, and for the red highlighted patients are those who didn't survive. That very interestingly, also the gut microbiota profile in hemodialysis patients would influence also the nutrition status, in that those with a better profile are also more well-nourished as compared to those who have the worst gut profile. So clearly targeting the gut microbiota is the future in developing the further strategies in renal nutrition and metabolism. And that we also need to change the whole concepts that the food is not just what we eat, but in fact is also a form of medicine where one could manipulate our food in order to protect our body organs both the kidneys and also save the heart. And here are some of the articles that were included in this special issue of the 45th anniversary. So as I've alluded to earlier, the different gut microbiota will be produced by, the gut microbiota will produce different metabolites. So some of these metabolites are more favorable. However, some of these are actually non-favorable, and as outlined here, and that could lead to more bacterial translocation or so-called the leaky guts. And so a healthy diet, as outlined here, ameliorate inflammation and oxidative stress. And so just to illustrate some of these key principles, for instance, if you had intake carbohydrates that would generate short-chain fatty acids, which could increase energy availability. But on the other hand, if you had a lot of high meat intake, it would increases the carnitine generation, which would further result in the metabolism through the liver to develop this so-called the TMAO, trimethylamine anoxide, and that could have an adverse effects on both the kidney and the heart, leading to various comorbidities, because there is experimental data to show that the TMAO actually reduce the reverse cholesterol transport, increase the activation of macrophage foam cells that could increases atherosclerosis. It also increase endothelial cell activation, inflammation, and platelet reactivity. So these data suggest how the diet interacts closely with the gut microbiota to contribute to cardiovascular, kidney, and metabolic health. So we do have different studies in the human to show how diet, like if you have high red meat intake, increases the risk of kidney failure, or a high red meat intake by generating the TMAO and related metabolites, it increases incident cardiovascular disease among older adults. So these are some of the other studies that not only does it got elevated in CKD, but it increases or correlates with the coronary atherosclerotic burden and increases the risk of cardiovascular disease or adverse clinical outcomes. So therefore, the food is one of these gut microbiota targeted interventions that would have a potential impact on kidney health, and that we do need to further investigate their effectiveness. So here I outline some of these strategies, like a plant-based diet, or even prebiotic, probiotic, or symbiotic supplementation, but these needs further intervention. Or one may need to target subjects' constipation as well to ameliorate the constipation potentially for kidney health, because there do have data to suggest the link between constipation and CKD. Fecal microbiota transplantation or intestinal dialysis or exercise are some other novel potential therapeutics that would warrant further investigations. However, if we summarize what data we have for a healthy diet for CKD, there are some systematic review as outlined here in one of these paper in CJ's in 2017. So you can see the total population is over 13,000. However, just to remind that all these are observational studies. But what they demonstrated is a very positive signals about adopting a healthy dietary pattern would be associated with a lower risk of all-cause mortality by about 27%. And there is also more recently another systematic review looking at the different modifiable risk factors for primary prevention of CKD, and that if you break down into the different components, of which I just want to highlight to you the dietary factors and the physical activity, and that these factors clearly, high vegetables, high phosphate, high potassium intake, and physical activity, they all reduces the risk of developing CKD. So also just last year, there is a study based on the UK Biobank study, which included over 140,000 subjects from UK, looking at how plant-based protein diet is actually reducing the risk of incident chronic kidney disease. There is also some other studies, not just from UK, but for instance, from this Asia studies from a large national database from Japan. What they do is looking at the different lifestyle factors. And I just want to show you not just the diet, but say, for instance, if you skip the breakfast, for instance, it increases the risk of a rapid decline in the eGFR over 2 years in older adults with type 2 diabetes. There is also some other studies looking at diabetic population, showing how adopting a healthy lifestyle, life essential 8 scores, reduces the risk of incident macro and microvascular disease complications. So the UK Biobank study has also had another publication over nearly 150,000 subjects looking at the adherence to the life's essential 8 factors and incident CKD. Now, I just want to draw your attention that here is this DASH diet score or physical activity score. They are among these 8 essential factors that would contribute to this population attributable risk in this population. And that if you look at the risk of incident CKD over a short term, like up to 3 years, one may not see a difference. But if you follow these subjects over a 10 years time frame, clearly if you had a high adherence to the life essential 8 factor score, you reduces the risk of incident CKD substantially. And that you can see how, if you interpret from these diagrams, that if you have a higher life essential 8 scores, the risk of CKD, incident CKD, were much lower. So shifting to a healthy diet is not only just important for kidney health, but it is an important strategy to prevent the global burden of non-communicable disease and also for sustainable planetary health. So in the Eat Lancet 2.0, they have shown how actually having a healthy diet actually reduces the empirical disease risk by about 23.6% and the global burden of disease by 22.4%. And that translated to reducing nearly 11 million adult deaths per year. And that is very significant. So in this chapter by Carla Avesani, she has reviewed the importance of planetary health, nutrition, and kidney disease, trying to connect the dots for a sustainable future. And she has highlighted how unhealthy diet would not only destroy our planets, but actually increases all these metabolic diseases and also CKD. So it is essential that we target at our patients' diet or the population in terms of building a healthy diet. And by that I mean a plant-based diet, having low protein intake and no red meat, having no ultra-processed food, and that not only would have a positive effects on population health and also patients' health in terms of their metabolic profile, non-communicable diseases, but it also decrease the deforestation for the livestock protection and production and protects from damaging the soils. And by doing so, it actually improves soil quality for growing more healthy foods. And shifting this cycle from Western diet to a plant-based diet also helps to reduce air pollution as well as our environmental pollution. And that it actually preserves our biodiversity as well towards a healthy planet. I also want to present this article to you, which is in one of the articles in this special issue, looking at these new insights into the dietary approaches to potassium management, because having a plant-based diet will also promote a higher potassium intake, and that could actually be potentially beneficial for the blood pressure control, because in our gut there is this sodium-potassium switch. That it's not only that we need to restrict sodium intake, but that if you increase the potassium intake, it promotes this switch and also lowering the blood pressure of our patients. And so one of the key messages is that we have to change the whole concept in avoid overly restrict the potassium, We have to avoid ultra-processed foods because these foods actually contain potassium additives. And this is what we need to avoid and minimize. But rather, we should not avoid patients to take a healthy dietary pattern. And when we adopt patients with a healthy dietary pattern, one of the key things is it would also help to ameliorate metabolic acidosis. So other than using oral drug, like oral alkali drug, in fact, building a healthy dietary pattern, as shown by this systematic review, has been shown to actually slow the rate of eGFR decline and reduce the risk of kidney failure. So you can see how all these studies, most of them fall towards the left of the line of unity, favoring the intervention, whether be it the dietary intervention or using oral alkali drug. And so that's why the KDOQI guidelines have also made these recommendations on reducing net acid production through an increased dietary intake of fruits and vegetables, and also try to maintain a serum bicarbonate of 24 to 26 millimoles per liter. So clearly, building a plant-dominant low-protein diet applicable not only for the population, for our kidney disease patients, but also in patients who decide for conservative or preservative kidney care without dialysis. So Connie, we summarized this article in this special issue, anniversary issue, showing the various benefits with this Plato diet in our patients for beneficial for the conservative kidney management. Now, and this does not exceed, only limit to patients who have CKD. In fact, even for patients who have undergone kidney transplantation, having a nutrition management or dietary intervention with a plant-based healthy dietary approach would also benefit to subjects with kidney transplant. So in this special issue, we also fostering a clear message providing an evolution in the dietary phosphorus management, and that is we now focus on a less restrictive diet for our patients, but more on the trends in terms of the biochemistry, and that we need to identify the hidden source of phosphorus from the ultra-processed foods with phosphate additives, because that's critical. So rather than restricting healthy foods that contain phosphorus, one should try and minimize patients to take their hidden source of phosphorus from ultra-processed foods, educate our patients to read food labelings, and also avoid them that could help to significantly lower the phosphate levels in patients with kidney disease. So one of the key evolution or change is that the recent guidelines shifted emphasis towards considering the phosphorus source, whether it's from plant-based versus animal-based, as well as examining the bioaccessibility of phosphorus. So here is this diagram showing the so-called the phosphorus bioaccessibility qualitative gradient, and that one needs to take consideration with the source of the phosphorus, whether it's plant-based and the animal-based, and that this is very important because the so-called the food with the phosphate additives, they are much more bioaccessible, and so we have to try our best to avoid this unhealthy foods in our patients. But for the plant-based proteins, because they have the phytate that could impact the absorption, and so one should not limit these kind of food sources, and that would shift the paradigm in managing phosphates in our patient. Now, last but not the least, I would like to mention about sodium management in patients with kidney disease, because it's an old story, but that brings new tricks for our patients, because we know very long-standing from history that how the sodium intake might actually increases the risk of blood pressure volume, increases hypertension, increases non-doping, increases adverse clinical outcomes, including both to the heart, to the brain, and to the kidneys, and ultimately increases the death of our patients. However, we also know that very low sodium intake might also contribute to increased adverse outcomes, but that may reflect subjects who have poor nutrition intake, protein energy wasting, and that may actually be the real factor that increases the adverse clinical outcomes in these patients. So here in one of these chapters, in another seminar in nephrology that we recently released last year, Cal Kissler discussed with his group, reviewed in this paper about a multifaceted approach in sodium management. That is, we need to target the sodium levels, not at the patient levels, but also at the industry levels, at the government levels. We need to have a clear food labelings. We need to decrease food in processed foods or in restaurant foods. We need to reformulate them. And in terms of the patients, we need to provide dietary counseling, advising them a healthy dietary pattern. They need to learn to buy their food items, learn to understand the food labelings, mostly avoiding the ultra-processed foods, promoting and encouraging a home cooking environment, and also building up a healthy dietary pattern. It's important in sodium management and other dietary aspects management that we actually develop patient self-management strategies through education, through their self-monitoring, and also motivational interview as well as behavioral counseling. With the development of artificial intelligence, we can also use a web-based self-management and e-coaching as well. There is also the use of these salt substitutes which have been tested, but just to caution that this approach would only be applicable for patients who have no significant kidney disease. So it's not advisable for those with CKD3 over 3, CKD3 or worse. So there are 10 key ways to cut salt intake, and as outlined in the KDIGO guidelines, both the CKD diabetes guideline as well as the KDOKI nutrition guidelines, both recommended having sodium restricted to less than 2 grams salt a day, around 2 grams salt a day, or 90 millimoles sodium per day. Now, but how to actually implement it? So there are 10 key ways to cut salt intake. First, we have to be really clearly identify the food items that have high salt intake. We need to educate patients to read food labelings, use salt-free spices, use fresh foods products, avoid processed foods. The ultra-processed foods are all high in salt content. And when you eat out with in the restaurants, try to advise the restaurant to cut your sauces and dressings, put them in separate dishes. So not only are the salt intake, but in fact, vitamins are very crucial for patients' health. So here is a review article that we have written where the vitamin supplement use is required in our patients with CKD. Now, as we know, there are different vitamins. As outlined here, the lacking of these vitamins can contribute to different clinical manifestations. Now, there aren't enough time for me to go through everything, but I just want to draw your attention that it is therefore very key to build up a healthy, balanced kidney diet for our patients, and that if patients are taking a healthy kidney diet, probably we do not need a supplementation on their vitamins. So therefore, several guidelines have actually mentioned and recommending a healthy dietary pattern. So here is this KDOKI guidelines recommending a Mediterranean dietary pattern, increasing fruits and vegetables intake. In the KDIGO 2020 diabetes guideline, they also recommend patients with CKD and diabetes a diet high in vegetables, fruits, whole grains, fiber, and legumes, plant-based proteins, unsaturated fats and nuts, and lower in processed meats, refined carbohydrates, and sweetened beverages. So here is this guidelines from the KDIGO, where you can see how the diet and the exercise or lifestyle self-management form the basis in the kidney heart risk factor management. And that this plate is actually what our patients should be adopting in terms of the healthy diet. We should try and promote more plant-based proteins, whole cereals, and starchy vegetables. However, what we want to mention is that currently, the world lacks personnel or healthcare professionals to provide kidney nutrition care. So according to this Global Kidney Health Atlas survey that we did jointly for the International Society of Renal Nutrition and Metabolism, as well as ISN, we surveyed 182 affiliated countries, and that we found that only 48% of the countries have dietitians to provide kidney counseling, and that 23% of the low-income countries never provide dietary counseling to their patients, and that also 41% of the countries do not provide formal assessment of kidney nutrition, and that dietitians and nephrologists only communicated sometimes in 60% of the countries. So clearly this is a huge gap area that we need to improve. So in this special issue, 45th anniversary issue, we also have this review article providing some insights as to how digital health technologies and our care models may evolve in the future for CKD nutrition management, and also for our patients or population to build up a better kidney health. So there are a lot more areas that we need to research. So therefore, I would like to give my concluding remarks, and I hope I have convinced you that lifestyle intervention is an essential lifespan approach for both kidney health and for lowering the huge global burden of non-communicable diseases. And that we need to adopt a healthy dietary pattern that are high in fruits, vegetables, whole grains, fiber, legumes, plant-based proteins, unsaturated fats and nuts, and avoid ultra-processed refined foods and beverages in all patients with kidney disease as a lifespan approach. And we also need to transform from a negative and a restrictive culture in dietary intervention to promoting a positive, healthy dietary concept for all our patients to eat smart and feel well with a kidney healthy diet in order to maintain kidney health or even to prevent kidney disease. And that we recognize that, not one size fits all, and that we do need to adopt a precision nutrition and a person-centered, individualized approach with shared decision-making in order to maintain cardiovascular, kidney, metabolic health, and that would require multidisciplinary collaborations. So with this, I would like to end my talk by just acknowledging everyone who have contributed to the 20th Congress of the ISRNM and the Society 2 years ago that celebrate the 45th anniversary of the Society, together with this 45th anniversary special issue in the Journal of Renal Nutrition. And also thanks to the journal editor, Cam and Linda. And that I would also like to promote this, invite you all to join the next Congress, which is later this year in August, from 28th to the 30th August, which is also in the city Hyderabad. And the Congress will be hosted in this country. And so may I welcome all of you to register for this coming exciting Congress event for ISRNM. Thank you very much.